Assalamu alaikum. Good morning. When we talk about CSF leak, we come across different terminologies like primary, idiopathic, spontaneous, secondary, traumatic, iatrogenic, high pressure, high volume, spinal or cranial, CSF rhinorrhea or CSF otorrhea. I'll start presenting few cases of primary and secondary, and we'll discuss it through later. The first case, 64 female, presented, she had a primary leak, which had endoscopic repair for it in 2009, but failed, then has a transcranial repair in 2011, also failed. In 2012, I did endoscopic repair for her. 10 years later, is still holding. I use a dura and bone graft. This is just a CT scan to show the craniotomy done before. And this is the post-operative. What we do is that we do a full endoscopic sinus surgery. We clear and explore the floor of the anterior cranial fossa and detect the site of the leak and try to repair it. The second case is 47-year male who had first 3 times between the years 1996 and 2006. He developed a CSF leak on 2014. That means 8 years later or after his last test. So we call this secondary or primary or delayed secondary CSF leak. Okay. Had endoscopic repair in 2004 using the dura and glue, which failed after a few months. And then he had another endoscopic repair in 2016 using a muscle and a dura or fasciolata. Also had recurrence in few months later. I did endoscopic repair in 2017 using the dura and bone graft. As you can see, I use bone graft in the recurrence because the defect is usually larger than usual, and you need the support to the graft you put in there. So still holding till 2022. This is just a CT to show you the graft, the bone graft I put, which is taking very nicely there. This is, I think it's 1 year later. It's holding. Another case, 50 years old female. She has a history of clear rhinorrhea on the right side of 5 years duration. No history of surgery or trauma. We did beta transferrin was positive. MRI showed left frontal encephalocele. And bilateral, I did bilateral exploration of the anterior base of the skull and repaired using a composite septal cartilage and mucosal graft in January 2021. Till now, it's holding. There is no leak. This is just to show you the CT scan, the preoperative CT scan with the encephalocele here, over here as well. This is a video during the operation, and you can see there is a fracture line here, but she has no history of trauma. And this bone is overlapping the other bone, and where the suction is the leak, and you can see the encephalocele coming through that gap. That's the navigation, which is very helpful sometimes in this kind of surgery. Now we remove this piece of bone and expose the dura because you cannot graft the dura on it because so we remove the fracture and this is the dura. And so you can see the encephalo seal in the encephalo seal when you retract the dura. It's repaired with a composite graft, septal cartilage with the mucosa. This is in place. Anyway, I'll show you later a better example, more live example. Anyway, okay, the most important thing is that you keep the sinuses open and clear. So, and you remove all the disease and keep a good drainage of the sinuses because it will be very difficult to reoperate on them in the future if they develop sinusitis and nasal polyps. The other case is 49 years female, presented with left primary CSF leak of few months in duration. She refused the repair or intervention, but treated conservatively with diuretics to decrease the intracranial pressure and positioning of the head. She sits for 30-degree and sleeps 30-degree head up for 1 month, and then the CSF stopped spontaneously in 2012. 9 years later, she developed recurrence and presented with meningitis, referred to neurosurgery for repair, but she refused the repair again. So the question is that what do we do with those patients who have a leak every 10 years or every 8 years and it stops with medical treatments or stop spontaneously? Should we operate on them or should we leave them and see them whenever they develop the CSF leak and give them medical treatment? And that's all. If you have any opinions, please, we'll discuss it in the after the presentation. Now, this is a CT scan just to show that there is no defect in the ethmoid roof or the base of the skull. Okay, the other case is 30 years old female. This is also an interesting case presented this January, 2 months ago, with recurrent left sudden gush of clear rhinorrhea since 2016, 6 years ago. The last attack was 5 months ago. She had, insignificant head trauma in childhood. She has a history of blurred vision and headache, and she was treated as undiagnosed and treated as migraine. Has no history of meningitis, and she received treatment for suspected intracranial pressure, which is stopped because of leg numbness. Examination of the nose showed right small polyp, and the left side showed no CSF evidence of CSF leak. I sent her to ophthalmology to exclude the increased intracranial pressure, but the fundoscopy was normal. Neurology sent her back with a provisional diagnosis of migraine. We did a CT scan with contrast, which showed actually bilateral frontoethmoidal disease with a maxillary cyst. These are the CT scans, and there is no defect in the base of the skull. So what do we do here? We can't collect the fluid to confirm it's a CSF leak. CT scan doesn't show dehiscence or a leak. It starts and stops spontaneously, only a sudden gush of fluid coming from the nose. And the periods between the attacks are so long. So should we do cystoscopy? Should we explore the base of the skull, do bilateral endoscopic repair if you find one? And is this the cause of this gush of clear fluid? Is it allergic rhinosinusitis with collection of fluid in the sinus, and then when she moves the head, the gush, the fluid comes out? Or is it sudden rupture of the sinuses, as we saw in the her CT scan? There is a cyst on the right side, but maybe there is another cyst which forms every now and then in the other sinus, in the other maxillary sinus. So what to do with her sinusitis now? Do you think we should explore? Should we do endoscopic sinus surgery and clear the disease, or should we treat medically? I treated her medically for the time being. Another case is a 58 years old male presented January 2022 with high volume, clear rhinorrhea and recurrent headache. He had a previous attack 2 years before, which lasted for 2 months and stopped spontaneously. He had FIS in 2009. So he had FIS in 2009. 9 years later, he develops a CSF leak, which stops spontaneously. And after 2 years later, he develops another profuse CSF leak. Endoscopic examination showed signs of nasal surgery, sinonasal surgery with high septal perforation, which I think it was part of the operation to do modified or just to do complete the surgery, open the frontal sinuses to each other. And he has also left, was obvious left clear rhinorrhea. MRI showed left cribriform defect with small meningocele protrusion, referred to a neurosurgery for transcranial approach. Always we refer the CSF leaks to neurosurgery to get their opinion regarding the transcranial approach, transcranial repair, especially in the primary cases, and especially in the recurrent CSF leak after surgery, transnasal surgery. But the patients preferred the transnasal approach. This is the CT scan, which shows the meningocele and the bilateral defect. MRI confirmed that meningocele. So we did the surgery. There was a large 1 centimeter left cribriform defect with meningocele and small right defect. The cisternogram showed bilateral olfactory accumulation of contrast. Beta transferrin was positive. He was started on acetazolamide, stopped 6 months post-operative for weakness in the thigh and the knee. This is the cisternogram, which showed the accumulation on both sides, accumulation of the dye on both sides, and the meningocele protrusion into the nose. So we did the transnasal approach. We did first we inserted the lumbar drain. There was 1 centimeter defect, mucosa removed from the surgical field, dura dissected and elevated off the bony margins, the dural graft inserted and tugged under the bony margins, and bone chips and putty laid on the dural graft. And then I did the rotation flap of the left and right middle turbinates to close the defect and support the graft. Of course, when we do these rotation grafts, you have to be careful to remove the mucosa from the surface, which is going to support or be underneath the graft. Removing the mucosa is very important because it prevents the development of mucoceles in that site in the future. And then you apply the glue on it, Miracil packs inserted. Started on antibiotics, gone to ICU for 3-4 days. 5 days later, the lumbar drain removed, and the packs was removed 10 days post-operative and discharged next day. This is the MRI 1 year later, which showed the closure of the defect, and you can see the rotation. There is no middle turbinate in its position. It was rotated medially on both sides, and the report saying that there's significant soft tissue changes affecting the anterior ethmoid air cells, which appear inseparable from adjacent cribriform plate and anterior cranial fossa. That means our rotation flap worked. The post-contrast images showed no evidence of abnormal meningeal or parenchymal enhancement detected. Now, what we use in these repairs, this is the DuraGen, which I used before at the start, and it was available at maybe in 1999. That's the first one. You can see it's hard. And now we're using the Durepair or DuraGen, and we use bone graft, cancellous bone, and demineralized bone putty. The Durepair comes like in this form. You can see it's very pliable, stretchable. It's very nice to handle. So Durepair, it's a regeneration matrix, consists of both type A and type 3 collagen. Type 3 fetal bovine tissue has gone through a process to remove the cellular components. This leaves undamaged pure collagen that acts as a neutral tissue. The entanglement or the woven of the strong collagen cables form a highly porous material matrix. Typically, it's 10, 20 micron pores. This doesn't allow the CSF leak through it. And the matrix will act as a scaffolding for the ingrowth of fibroblasts and blood vessels. Durepair, a non-synthetic dura substitute for repair of the dura mater during the neurosurgical procedure. It is strong yet flexible collagen matrix that can be applied as an onlay or a suturable graft. That means we can suture it to the, in the neurosurgical, they can suture it to the original dura. And the characteristics of the Durepair, it's very flexible, can be used as an onlay or a suturable graft, conforms to the patient's own dura, can be trimmed wet or dry, and the graft adheres well to native dura. The collagen matrix, as we said, creates a product that is strong yet pliable. Collagen matrix seals around suture holes to avoid CSF leak. Porosity of material allows for tissue ingrowth. It is easy to handle and reposition when wet, easy to prepare for surgery. It only takes 30 to 60 seconds to hydrate. The bony cancellous bone that we use, cancellous bones consist predominantly of trabecular bone tissue, has higher osteogenic and osteoinductive properties than cortical bones and a larger number of cells and osteoclasts. The structure of cancellous bones allows rapid revascularization of the graft. This is the bone putty, comes in this form. It has osteoinductive potential. It is demineralized, as you know, has a natural growth factors trapped within the cortical bone. It has high residual calcium levels in it, which is provides optimal osteoinductive potential, and also contains fibers, which provides a natural architecture with increased surface area to encourage cellular attachment. Now, the dilemma of lumbar drain. Should we put a lumbar drain or not? A lumbar drain has been advocated for planned treatment of CSF leak. However, no prospective studies have examined the use and duration of lumbar drains in patients who have experienced iatrogenic endoscopic sinus surgery injuries. In most instances, a lumbar drain is unnecessary for an iatrogenic injury unless the patient has signs of benign intracranial hypertension, empty sella syndrome, or radiographic evidence of deficient bone along the skull base that would otherwise suggest elevated intracranial pressure. I'll show you some films. This is very fresh from last week. That's Sunday. This is electrogenic. And
Jamal, could you please mute the videos so we can hear your voice instead of the video?
Okay. Uh, right. You can see now this is the defect. You can see the injury is done. Even you can see the brain tissue through it. And there is the leak coming. Rahim. Okay, here we go again. This is the another shot. Sorry, I didn't prepare it because this is a very recent one. Now we prepare the area around the defect, remove the mucosa, and try to make it clear. Now, and then we place the dura. I show all the steps. We place the dura here, and you can see this is the graft prepared here with the mucosa and the graft, the cartilage here. And now we're preparing putting the dura in place. Okay, and this one we will put the graft in there. We put the dura, the composite graft there, and you can see there is a still leak. There is something wrong. Dr. Wissam was observing, and he suggested that we have another look because the graft was shifted laterally. So we
Doctor, we cannot hear your voice clearly.
no. So Wissam suggested that we have another look. So we had another look, and so the graft was shifted laterally. We had another look.
Put the blue.
You see the graft is shifted laterally. Right, repositioning of the graft. Now, we're putting the graft again. I'm putting the composite graft again in position. And we do the suction. There is no leak now. So the graft is in place and the seal is working. Then, of course, we put the glue on top of it.
Put the glue.
Put the glue on top of the graft in the area. And then we insert a small mirror pack in the to support the graft, and then maybe another mirror pack in the nose. Okay, thank you very much.
Thank you very much, Dr. Jamal. الله يعطيك العافية. So we have like 10 minutes for discussion if anybody has any question. I think the main issue was most of the things that I think about in CSF leak in patients post-surgery who has sudden gush once or twice and then it stops. So do we need to deal with them and do investigations for them, or just we neglect this, and if it does not repeat, we just reassure the patient? What do you think, doctor? Sometimes after like 2 weeks, the patient comes to us after sinus surgery or even septoplasty with a presentation that describes a sudden gush of CSF leak that stops spontaneously, and then it does not repeat.
Post-operative CSF leak sometimes it stops spontaneously. When do we interfere? At what time? Is it when the patient comes after a week with the CSF leak? Should we explore him and repair? What if he comes after 1 month with a CSF leak? When do we explore? Most of us, if they come early with a CSF leak, within days, yeah, you have to explore and repair. If it comes later, maybe we should give time for the spontaneous recovery, for the spontaneous closure. My experience when I was in neurosurgery, when we have head trauma with CSF rhinorrhea or CSF otorrhea, actually we wait for 6 weeks before the neurosurgeon interferes and repair, because most of them within 6 weeks, they stops spontaneously. The healing process takes place and stops spontaneously. Whether this works the same in post-operative endoscopic sinus surgery, I think for me, in the first few days or immediately in the post-operative day, I would take them to OR again. But if they come later, I would give them a chance for spontaneous healing, for spontaneous recovery. Because natural healing process is great in the human body. The primary one is the dilemma. What should we do to the patient? If the patient refuses surgery, that's okay, he will solve the problem. But if the patients give us the choice what to do, to repair or to leave, this is the dilemma that we will face. Should you advise the patients, yeah, let's do a repair, which may fail, especially in the primary. The repair may fail, as we saw. They do endoscopic failed, and then transcranial failure, then endoscopic again failed, and for the 4th time, it's holding up till now, but I don't know if it's going to fail or not.
But good morning, doctor. But what the causes of failure, doctor? Is it intracranial pressure? Is it multiple holes, multiple sites, or the same site, or failure of the graft?
It's all what you said, Dr. Aqil. But mainly is, you see, most of the surgeons, they repair it with a mucosal graft, and they leave it, and even without mucosal graft, and they put a glue. And after a while, this grafted area will sag. It comes lower down because of the CSF pressure. And sometimes, of course, if the pressure increases for one reason or another, this dam may break and you have a CSF leak again. The size of the The size of the hole or in the base of the skull, the defect is also important. If you have a large one, like 1 centimeter or more defect, this, of course, it will not hold by a dural graft only. You need a bone graft. You need something strong to support it. Even the bone graft, you have to put something underneath to hold the bone graft in place for a while. That's, I usually do a rotation flap if, of the middle turbinate if they have middle turbinate left from previous surgery. And then you put a Mericel pack there. The mirrors always keep the packing light. Don't put any pressure on the area of the graft because this is leads to necrosis and leads to infection. Yeah, the size of the defect is very important. And
يعني I
the,
think إنه recurrence mainly happens with the spontaneous CSF leak. يعني traumatic rarely to see recurrence because the underlying cause is not treated. If the patient has intracranial pressure high, of course, any weak area will leak. And also there is multiple leaks. Sometimes there is another leak and you can't see in the surgery through the surgery. The other question, Dr. Jamal, about the diagnosis, you mentioned cysternography. When you do it, CT scan, cysternography, if it's negative, are you do MRI cysternography, dynamic one? They are not doing here in our hospital because it must be active leak to see the leak through the CT scan cysternography. But MRI, they can do it like a dynamic, yani 2 or 3 times per day to see if there is a leak. What do you think about this issue?
like dynamic MRI is very useful, but it's very difficult and time consuming, as you know. So I don't know. I have
They
not
are not doing here in our hospital.
I have no experience with the dynamic MRI for the CSF leak. They don't do it. I asked before for dynamic MRI for the sleep apnea, but they couldn't do it.
They couldn't do it. Mm.
I have no experience in that, Dr. Akhi. Maybe you can enlighten us about this.
No, no. I asked our radiology. They didn't have any experience. They are not doing it. The other question, to do surgery and not to do surgery, I think if you can see the defect, I think you have to do the surgery. What do you think? But
Well,
if you can see the defect or it is very difficult side, lateral sphenoid something, and this is the other question is to observe or to treat conservative. But if you can see active leak and there is a defect, I think the first choice to do the surgery. What do you think?
yeah, if you can see the defect, if you can see the CSF leak, and you can see the defect on the CT scan or MRI,
Exactly.
which matches the site of the endoscopic leak, then yeah, you don't need to do cysternography or such. But cysternography is, as you said, is it will detect if there are any other sites. You see,
Exactly.
some other cysternography shows bilateral accumulation, but actually when you go there and explore both sides, you'll discover it's only one side is leaking, the other side is not leaking. There is bone there, and the CT scan is very deceptive in detecting the defect. Sometimes we suspect a defect, but during surgery we find no defect. I'm sure you experience that as well.
But you are always explore the other side, huh? If you have spontaneous.
Patients saying, no, spontaneous. If it's unilateral, we explore only the side of the scene. But if it is bilateral, you explore both sides.
Both sides.
If it's bilateral, I would send the patients to neurosurgery to do transcranial.
Mm-hmm.
If multiple sides, it's also better to do it transcranial rather than going endoscopically and find bilateral or find anterior and posterior gaps. And it's very difficult to repair. While in the In neurosurgical, they will put a big piece of dura repair and put a glue on it and suture it to the other to the native dura, and that would be easier and more. I think it's better for the patient. Very
Yeah,
tough.
but it's craniotomy, يعني.
We have less than 1 minute. Would you like to extend? Would you like me to do it again? It will stop in a minute. Is there any other questions? Would you like to continue the discussion with the link again?
No, we can discuss it on the WhatsApp. Oh, it's up
Yeah.
to you. Does
I'm
anyone?
clinic.
Okay, so yeah, just finish your questions now. Okay.
But the question for Dr. Jamal, to give antibiotic or not to give? You can answer in the
You give
WhatsApp.
antibiotics intraoperative, and I continue post-operative, of course.
For how long and what do you give?
I give vancomycin and other antibiotics which causes the blood-brain barrier.
Thank
And
you.
we give it for 10 days, more than 2 weeks maybe, until we remove the pack.
Thank you, Doctor.